All right, we are beginning our webinar now, our monthly Grand Round series. Welcome everyone as you're joining. Okay, as everyone's getting logged in, just a few housekeeping items that we do at the beginning of each of these. First and foremost, welcome to our Baptist Behavioral Health Grand Rounds. We thank you for joining us. I'm Dr. Francesca Varello-Sims, Director of Education and Training for Baptist Behavioral Health. So before we do begin, a few notes. If you have any questions for our presenter, you can either submit them into the chat directly or into the Q&A box. I'll be monitoring those throughout. Some questions Dr. Irizarry Mendez might choose to answer throughout, or we may hold them to the end during our question and answer time. If you have joined from a mobile device that's not connected to your Baptist Health Zoom account that shows your name, please go ahead and sign into the chat and add your credentials. So at this time, I'd like to welcome Dr. Alexander Irizarry Mendez. He is our current clinical health psychology fellow at Baptist. He is a bilingual clinician who was born and raised in Puerto Rico. He received his PhD from Ponce Health Science University in Puerto Rico. And Dr. Irizarry Mendez spent a significant amount of time of his working with people that have complex medical conditions and neuropsychiatric diagnoses. After the catastrophic passage of hurricanes Irma and Maria, he collaborated with the USPHS, so the United States Public Health Service, at established field medical station in Puerto Rico, providing clinical support for the displaced survivors. He provided first psychological aid in communities and shelters after the catastrophic hit of a 6.4 earthquake and its aftershock on the south of the island. Further, during the COVID-19 pandemic, Dr. Irizarry Mendez provided psychological services for COVID patients and healthcare providers in the neurointensive care units and rehabilitation units. As a researcher, he collaborated as a data collector with Harvard Chan School of Public Health, quantifying mortality in Puerto Rico after Hurricane Maria. He also contributed to exploring oncological patient needs after Hurricane Maria. So welcome, Dr. Irizarry Mendez.
Thank you. Thank you, Dr. Barao. I'm very honored to be here with you. I don't know if you guys can see my screen.
Yes, we are good.
Perfect. Okay, cool. So I'm very honored to be here with you all sharing this topic, which is really significant for me. As Dr. Barao said, I have the opportunity to work with several catastrophes or disaster, and I just want to start sharing with you some of the photos. These photos are from Puerto Rico. I personally took some of them. The other ones are from the social media. So this was where my passion for this started. And this was like my first time working with different professions. I was in training. I was on my first year as a practicum student during my doctoral degree. So this is where I understand that it is really important to receive some training to provide psychological services and first aid, because we doesn't have that information at that time, and we have to learn it over the way. The third photo that you can observe here is the field medical station that I collaborate with the United States Public Health branch. And so I'm also, as you say, collaborate with different communities, providing some services, and you can observe that this earthquake were really significant in Puerto Rico. You can see one of the schools there, the streets, and even one of the hospitals. I am showing these photos because it's really important to understand that disasters, they're gonna be different depending of the area and depending of the resources that are available to manage the disaster. So that is why it's really important to have internal resources to manage or try to mitigate the effects of a disaster. So I would like to start doing the questions. I would like to know if have you ever received training in psychological first aid for disaster? And you can answer to these questions following the instruction at the top of this slide, which is you can go to a website or you can just text 22333. And once you join, you can pick up some of the responses there, okay? So I will give you some seconds to go there because I would like to know how many information should I be sharing with you depending on the experience that the person here have. We can see this in life. All right, so looks like in general, we have a tendency to see that the majority of the persons here, they doesn't have received like a formal training in psychological first aid, especially for disaster. And I'm gonna be sharing with you, apart from this, I'm gonna be sharing with you at the end of the presentation some websites that you can go to receive like a certificate and like a formal training in psychological first aid, if that is something that you are looking to pursue. So let's talking about some core terms and concepts in general before going to talk about like the rappel model per se. So what is a disaster? A disaster basically is an occurrence disrupting the normal conditions of existence, also which is increasing the level of suffering that a community have, or the capacity that a community have to adjustment to that disaster. As I was talking before, they are reflections of the way society is structured themselves and allocate their resources. That is why it's really important to have the information and have all the resources that we can have to mitigate those effects. The frequency of disaster caused by natural hazards has been increasing, and we're expecting that they are going to continue increasing considering all the weather changes and all the global things that are occurring right now. A hazard is a natural or human-made event that threatens to adversely affect the human life, property, activity, extent of the causing of a disaster. So that is really important because sometimes we can see that any event doesn't impact directly a person, but they can impact their property and they can be suffering, they can be having some reactions caused by that. So we can invalidate them. We cannot diminish that that is something significant for them. And we also have an emergency, which is a state in which normal procedures are suspended and extraordinary measures are taken to avert a disaster. So we're more familiar with the concept emergency in general, but we don't necessarily have been exposed to a disaster or have been working during a disaster. And we basically can classify hazards and disaster in two main origins or causes, the ones that are by natural causes and the ones that are by human causes. And you can see a list of different things that we can consider a disaster, which is like a hurricane, or also can be like a car collision or war, or things like 9/11 event. And they can be, or they can occur suddenly, or they can just occur progressively. The important thing is that we are gonna have a hazard human or naturally caused. And we're going to have the factor of insufficient capacity of response. So if we increase the capacity of response, we are going to be preventing a disaster, or we are going to be mitigating the effects of a disaster. And we are going to have some factors that we are going to consider part of a vulnerability, which are things such as underlying causes like poverty, like limited access to power structures, economy, age, and things like that. For example, in Puerto Rico, our location as an island, that is a vulnerability for us, and also a susceptibility. But it's a vulnerability because we doesn't have any other place. For example, here, if we have an emergency here in Florida, we can receive some help from other states. But in Puerto Rico, we have to wait to receive some help through an airplane or a ship there. So that is a thing that is mediating to the impact of a disaster. So we're going to have other things such as dynamic pressure, local institution, education, training, and other things like dangerous location, dangerous buildings, fragile structures. So poverty and their consequences in general. And when we are putting this in context, it is really important to understand that all of those things, they are gonna contribute to have a surge, a demand after a disaster. So a surge in the context of psychological first aid is the increased demand for health services after a disaster. So some studies were performed, and the conclusion of all of them were that more than 40% of the studies revealed that persons or the victims or survivors, they're gonna have severe to very severe interference with daily functioning. And that is very significant. So in general, it has been shown that the increased demand for mental health services may range from 50 to 25% of the population directly. So if you can imagine right now, we don't necessarily are under disaster, and we're having really long wait lists for psychological services. So imagine when you have a disaster and you have all of those people trying to pursue and trying to receive some help. That is why psychological first aid is really important, because we are gonna be there providing some help to mitigate and to decrease those numbers and percentages. This is a quote from an old book related to disaster, but it says, in hours after a disaster, at least 25% of the population will be stunned, dazed, apathetic, and wondering, suffering from the disaster syndrome, especially if the impact has been sudden and totally devastating. At this point, psychological first aid and triage are necessary. So it's nice because I think almost everyone here have heard or have worked with triage. And now we are going to be learning how to use those, or how to transfer those skills at the time that we are providing psychological first aid. So what is psychological first aid? Psychological first aid, according to the American Psychological Association, is going to be an initial disaster response intervention with the goal of promote safety, stabilize survivors, and connect individuals with help. It's not going to be therapy. It's not going to be a long-term intervention. You doesn't have to be a psychologist or a counselor to provide those services. You just have to have in mind that you want to collaborate to promote safety, stabilize survivors, and connect individuals with help or resources. It's going to be delivered to affected individual by mental health professionals or and other first responders. The purpose of PFA is to assess the immediate concerns and needs of an individual in the aftermath of a disaster and not to provide on-site therapy. According to Johns Hopkins guide, which is the main guide that I use to create this presentation, PFA is designed to mitigate the effects of acute stress and trauma and assist those in crisis to cope effectively with emergencies, including disaster and terrorist attacks. It's really important that one of the core things to consider when we are providing this intervention is that it's going to have a compassionate and supporting presence. So we're going to be learning through this presentation how to make that deliver with the survivors. Psychological crisis intervention is superior to multi-session psychotherapy post-disaster for reducing acute distress. And this is an example of a study that was performed after the 9/11 terrorist attack. So what it is shown is that if you help the people at that time, they are gonna be unlikely to develop any of the trauma symptoms. And that is why that intervention is more effective than waiting after disaster, waiting after all the normal or typical services are available to start working with any of the reactions that the survivor may have or the traditional services. Psychotherapy post-disaster may delay or complicate recovery. As I say, for example, in Puerto Rico, we have some clinics that they doesn't open until 6, 7, 8 months. So imagine some people having severe distress or psychological or physical distress, and they doesn't have access to any of, like help or anything like that. That is why it's really important to be able to address this really after the impact of a hurricane or any other disaster. Enhancing local search capacity is more important than the importation of external resources. And I can really relate with this because from my experience in Puerto Rico, we received some help from the outside. But for example, we received some psychologists and counselors, but they speak in English. And the local people, we speak Spanish. So it's really hard when we are talking about psychological help to be open or to feel that you are really receiving comprehension and understanding from other people of the outside. So the people that better know themselves, the better know their neighborhood, the better know the reality of their local. So that is why it's really important to enhancing and to providing some information in order to prepare for any disaster or catastrophe. Those outside the mental health profession can contribute substantially to community healing. However, will require knowledge and training in order to be effective. Resilient communities are better built from the inside out. So what is the RAPID model? What the acronym stands for is these 5 elements that are like the main thing here that I would like that you remember. And they are basically the steps that we have to take in order to provide an effective initial response or aid to survivors. R is for rapport and reflective listening. A for assessment, P, prioritization, I, intervention, and D, disposition and follow-up. And we're gonna be discussing all of them. So rapport in general, the rapport and reflective listening is really important because you want the survivors, you want the person that is receiving your help feel that you really understand what are you doing there. So the third step is to make contact, to introduce yourself and explain what are you doing here. You know, it might be really weird if you just approach to anyone and you are trying to ask things if you doesn't explain what is your role there. The second thing is that you are gonna try to increase their perception of understanding. So you don't necessarily have to understand. You don't necessarily have to be in their shoes. You just want to increase the perception that you are understanding what are they suffering or what are they dealing with. So saying that, the trick here is that you are gonna show them that the things that they are saying or the things that they are feeling make sense if you look the life in the way that they are looking at it. So maybe for you that doesn't make any sense. But if you take a moment and try to see the things in the way that they are seeing things, that makes sense. And the creator of the guide is a understanding often conveys trust, trust often conveys compliance. So we are gonna be using reflective listening, which basically is taking their words and you're gonna be rephrasing it, the content of what are they saying. So you can use some phrases like, sounds to me like you are really suffering right now, or you are deeply sad right now. What are you saying is that you look your home. What I am hearing you to say is that you were really afraid to lose your life. Things like that. Look for confirmation or clarification because everybody is different. So some people, they benefit from a compassionate approach, and other, they need more like a directive approach. So we're gonna be looking for confirmation or clarification while we are trying to validate the content and the emotion. So we doesn't necessarily have to validate the content every time, but emotions always, they're always gonna be validated considering the way that the person is thinking and the way that they are feeling. So allow them to express themselves. Probably you're gonna be like the first person that they are telling, you know, all the worries and things like that. And don't try to make the person feel better by diminishing any concern, and don't argue with them. Even if you think that they are like, you know, dysregulated and they are thinking in a way that is not efficient. The second component of the approach is the assessment of basic physical and psychological needs. And we're gonna have some people that they're gonna be in the spectrum between the absence of the stress and the other extreme, which is the severe dysfunction and incapacity in general. So we're gonna be trying to see where they are, and this is gonna be really important because that is gonna help us with the second stage, with the third stage of this approach, which is prioritization. So you're gonna try to remain as natural as possible, and you're gonna be trying to identify if they are like staying with a positive and motivation in the process, of if they are having like severe distress. So we're gonna have different, we're gonna have like different dimensions that we want to check. The first one is the cognitive dimension. So remember, this person, they're gonna be anywhere between the spectrum, somewhere between the spectrum. So you can have someone with some stress and they have some decreased ability to concentrate. They're telling you that they cannot remember some things, that it's hard to think about it. But if you have a person that is on the extreme of that, they probably might be like hopeless, or they probably are not able to remember their name or something like that. On the emotional dimension, you can have some person that they have some fear, they are really sad. But if you have a person on the stream of that, you're gonna have a person with panic attacks, you know? So we are talking about the most severe, the most significant part of the distress, which is gonna cause a dysfunction of those survivors. And we want to mitigate that, and we want to help them to be able to take care of themselves and other people around them. In a behavioral part, we may have some person that have struggling with sleep or with eating, but we may have other people that are using some medication or some things to cope with those behavioral things. So those are the problematics. Those are the ones that requires more help. In the spiritual way, we can have some person questioning their faith, but we can also have other person on the stream that are projecting the faith, and that is causing problems around because they're saying things like, we suffer from this disaster, hurricane, or something like that because we doesn't pray every morning or something like that. So they are promoting guilt on the community, and they can be causing some troubles around and complicating the things. So we also gonna have the physiological level or dimension of the reaction. So we can have some person that has some headaches, but we also can have other people that have significant physiological reactions. So basically, we're just gonna try to identify where in the spectrum the person are. So that is gonna help us to do like the triage, to think about how and to whom I'm gonna be providing my resources first, or where I'm gonna be putting my attention first. So the triage or the prioritization is an extension of the assessment, and we're gonna be putting some attention on safety, physical needs, and emotional needs. Why in that order? Because if you are having, like if you are bleeding or something like that, you are not gonna be thinking about being depressed. So we have to put this in order that we are gonna be protecting the life of the person that we are trying to help. And you can have two different approaches when you're doing the triage. The first one, it is called the evidence-based, and you're gonna be looking for diminished cognitive capacity, which is like insight, memory, problem solving, and things like that, because you want the person is able to solve the problems, is able to take care of themselves, because in that way you can help the community to recover faster. You also gonna be looking for an impulsive person. You're gonna be looking for the one that is probably causing trouble around because it's not able to regulate themselves, and because they are not able to act in a calm manner. And we're also going to be looking for some people that have diminished functional capacity. So they cannot take care of themselves. They are not going to work if they are able to eat. So that is one of the approach. The second one is the risk-based one, or the 3Ds for the subacute concern. This is the one that I usually use when I was in Puerto Rico. So you're gonna be looking for any ward that is in risk of death, any dislocation or injuries, and the third one, disable impact, or trying to identify how are you going to help them to resolve those difficulties. So the other part of this model is the intervention. And as I said before, you doesn't have to be a psychologist or a counselor to provide any intervention to them. Usually you are gonna be looking for things that the person had and work in the past for them. So we are basically talking about adults. So they have overcome things before. So we are gonna be trying to help them to think clear, to think better, and to identify things that work from them in the past and they might integrate or use right now to help them overcome um, this particular situation that they are having. And you have to be really creative there because it's going to depend on the resources that you have. That is going to determine how you're going to work with them. So the goal is to provide compassion and support, which might be just be there. We might be just hearing them, offer them a space to do the catharsis. And you're gonna be acting to reduce the distress and restore functional capacity. And believe it or not, some people, they might even benefit from you inviting them to collaborate with you to help other people. So the intervention phase basically have two steps. The first one is that we're gonna be trying to promote stabilizations in them. So if they are cognitive, physiologically, or emotional dysregulated, we are gonna try to do things to help them to be stable, to being stable. So how are we gonna do that? Well, one of the things that is really important is to remove the cues. Sometimes you can have a person that they lose their houses and they're just in front of the house and they're looking things that they're loose and things like that. So we are gonna try to put their attentions in another thing. But we have to have caution because we don't want to invalidate their process. But we're going to try to invite them to focus their attention in a different thing that help them to recover. Because basically, the reality is created from the things that you put attention. So we're going to try to remove the cues. We're going to encourage them to focus in different tasks that help them to move forward in the process. Um, and that is also going to help the survivors to delay the impulses that they might have. If we are able to stabilize them, or if you are meeting with someone that is stable in general, you're gonna try to do mitigation, which is reduce any acute distress that they might have. How are we gonna do that? We're gonna be providing some education. And education, it may go from different resources that you know and you can share with them. So you can normalize that. You can normalize the situation that they are having. You can instill hope, and you can provide any stress management techniques that you know. They might be things that worked for them before, or things that works for you, and you can say to them like, well, for me this works. I have tried this and this is something that helped me. What do you think if you try to do this? Because as I said before, we don't want to invalidate their grief in general. And we're gonna have the opportunity also to correct any false information that they might have or refrain with some like better information. Because for example, when I was in Puerto Rico, some people, and I traveled to different communities, they doesn't have like access or resources to go outside of their neighborhood or outside of their community. So they are thinking that everything on the place looks pretty similar to their reality. And we're gonna bring some outside information and help them to understand that everything is not lost, that there are some resources that we're gonna be using to start recovering. The last part of the model is disposition and follow up. So if the person seems that they are capable or more than capable of taking care of himself, herself, or others, your intervention is end. So you doesn't have to continue providing any help or services to them. This is really important because if you're thinking of disaster, all the resources are going to be limited. So we're going to be, we want to be wise about how are we using the resources and how are we putting our energies on helping others. If it is determined that the person cannot function independently or requires significant support from others, then we're going to try to facilitate access to further support. And that further support might include some family, friends, some help through their jobs, hospitals, disaster relief services like Red Cross, faith-based services. Those are great because usually churches are the better places that know the community in general. So those are great, and any financial help that you may know that is available for them. So basically, a follow-up can be helpful. However, and this is really important because remember that I say that this intervention is not therapy and it's not like long-term psychotherapy. If you find yourself providing a third one intervention, that should be a good moment to move further in the continuum of mental health services. We don't want to find ourselves playing to be a psychologist, a counselor, or something like that. We just want to stabilize, we just want to mitigate the effects, we just want to help them to cope better with the distress of surviving a disaster. So I have another question right now just to check how are you absorbing the information, and similar as before, in the top of this slide, you're gonna have the instruction to respond to this question. So I'm gonna give you some time. And the questions say, or the statements say, rapid acronym stands for report, assessment, prioritization, intervention, and disposition. And if you have any comments or any questions, you can put it in the chat, and Dr. Varela is helping me with that. And I also try to give you some time at the end of the presentation to make any questions. Okay. So I have different responses, yes and no, but basically the correct answer is yes. Rapid acronym stands for the different 5 stages of the intervention, which basically are rapport and reflective listening, assessment of the needs that might be physical or psychological needs, prioritization or triage, intervention, and disposition or follow-up. Thank you to everyone that is participating in this call. So now I would like to talk about self-care, which is a really important thing when we are providing services. And I found this beautiful quote which say, self-care is making your decision from a place of love instead of fear, so that they are decisions you can own no matter how hard it gets. This is really important when you are considering the contents of a disaster, because possibly you as a first responder are gonna be also a survivor. For example, in my case, I was also a survivor of the hurricane. I was also a survivor of the earthquake, but I was there providing services. So it's really hard to put some boundaries because we might feel the urge to help others and we can easily forget our own needs. That is why it's really important to talk about self-care. So there are some questions or considerations that we might to consider before going to a place to provide any services in order to protect themselves. So you're gonna going with a group to any place to provide some first psychological aid. When is gonna be that? Where? For how long I'm gonna be providing those services? Is there gonna be any transportation? That is really important. For example, I remember in Puerto Rico, we used to wait until 2 hours to put some gas on our cars. So I really want to make a good use of that gas to cover my needs, but also I'm using it to provide some services. So it's a good question to make, like, is there's gonna be some transportation to help that community? Reporting to whom? We're gonna have a leader, we're gonna be everyone by ourselves, how this is gonna work. Is there gonna be any malpractice insurance or cover or something like that? I'm just gonna be providing some services or some intervention as a person versus I'm gonna be using my license as a nurse or as a doctor to provide some services, and using the psychological first aid approach. What are gonna be my duties? Is gonna be a safe place? What are gonna be the risk? Is there gonna be some violence? Why I have to go there? That way, we're gonna be in groups, we're gonna have a partner, things like that. And how to handle violence, suicide, homicide, or any acute psychosis episode. So it's really gonna be so important to have some local protocol or some information about how are you gonna manage that? Are you gonna be the person in charge to deal with that? Is there gonna be any other provider, anyone with a license that we can just refer the person? So that is why it's really important to have this education before any disaster. This is why it's really important to have any plan in case that something happens. Because if you remember, I said at the beginning of the presentation that a hazard or disaster, they can occur suddenly and you might have to act instantly. So what are the consequences of a poor self-care? You can have some burnout, which is basically the result of, or the result from stress in your work environment. You can have some vicarious trauma, which is when a provider start feeling some symptoms very similar or even the same symptoms that a patient or a person that they are dealing with after a prolonged time. You can also have some compassion fatigue, which is basically an emotional or physical burden, which is created for the trauma or pressure of helping others. And I remember, well, I will wait a bit to share with you that you can get sick. You can also use substance to cope with all the stress that you are having or all the physical and emotional reactions that you are having. So you can also feel guilt, and that is the one that I want to talk about. It. I remember that when I was called to provide some services, I have some things that the majority of the population in Puerto Rico doesn't have. I used to live in a privileged area, so I received the electrical services like 1 week after the passage of the Hurricane Maria. But the majority of Puerto Ricans, they receive electrical services or they have access to electrical services and water 1.5 years after the hurricane. So I was prone to feel the guilt of having things that they doesn't have. So it's really important that you are doing things like this to manage your stress and to manage the emotions that you are having. So the first one is monitor yourself, monitor your needs, monitor your vulnerabilities. Because as I said, probably you also gonna be a survivor, but you are putting like an extra effort to help some people. And in order to keep you in a good standing to do that, you're gonna have to monitor your needs. Are you eating enough? Are you sleeping enough? Are you giving yourself a chance to process the things that you have seen? Because they're gonna be tough, they're gonna be painful. And it's really important to have a space to process that in order to continue providing some help. Acknowledge your contributions. Sometimes we might want to do more things, but it's really important to acknowledge our contribution. If we doesn't have the physical strength to do things, or if we doesn't have like economical resources to do things, we can acknowledge our ideas. We can acknowledge our contributions. We can acknowledge our leadership skills and things like that. The other thing is practice relaxation and hope. So relaxation is gonna be different for everybody. So you have to know yourself. You have to know what things works better for you. And you want to practice hope, because hope is something that you want to do actively. So you want to remember yourself that this situation is not going to be forever. Even if some of the consequence might impact some people forever, the whole situation, the catastrophe, the disaster is not going to be forever. So you want to practice actively that. And the last one is the interpersonal support. It's really important that you learn to rely on others, that you learn to say, hey, I need some help. I'm not feeling well. Maybe today I'm not feeling well to do that field trip. Maybe today I have to take care of my family. Today I have to take care of my own needs. And it's really important to learn how to rely on others. So I have one last question, and it's about compassion fatigue, because it's one of the most common things. So I would like that you guys join me with this one and tell me, what do you think about those statements there? All right. Yes, so definitely both. Compassion fatigue is the feeling that you have no more empathy left to give, and it can be associated with a very high workload or a non-supporting work environment. So basically, before this term, we have the concept burnout, and we have the concept of trauma or secondary stress reactions. But now compassion fatigue is like a global term that is including all of those scenes that you can have when you are providing some services, even in a short term or in a long term, and they are causing emotional or physical burden caused by trying to help others. So these are some resources that I want to share with you. If you're looking or if you are pursuing to have further training in psychological first aid, you can go to any of those links there, and we're gonna have the PowerPoint available for your requests. So we have the National Child Traumatic Stress Network, which is interesting because it's one focus on the children. We have the National Association of County and City Health Officials, and we have the Johns Hopkins Center for Public Health Preparedness, which was the one that I took when I was doing my training. You can also ask your license board, because sometimes you can put yourself there, you can enroll yourself there as a first responder voluntary when they have any disaster in your country. So if you feel that you would like to collaborate there, you can check on those things also. And I just want to end this presentation with this quote, which say, "Rebuilding a community as it rises after a disaster is a huge effort and does not happen overnight. Lend a helping hand to those in need." Those are the references. And now I just want to offer some space if you guys have any questions, or if Dr. Barello, do you have any questions?
Thank you so much, Dr. Irizarry Mendez. So we do have a few questions. Before we get into that, I'm going to share my screen so that everybody can have the QR codes for the evaluations. The first one, while I'm doing that, is Linda Spadaro. She's one of our managers in Baptist Behavioral Health. She asked how PFA is different from CSID. I personally am not familiar with CSID, but Linda, if you would provide a little bit more context in the chat about what that stands for. I know the hospital has their own specific ways of responding to crises, like the CISM program and things like that. So we'll wait for some more information on that. Shamira asks, is the training done online, the one that you did?
Yes.
Okay.
And it's really good because they have some videos about how you can do it and how you are not supposed to do it. So
Okay.
It's a really good training.
Excellent. In thinking about the types of psychotherapy or theoretical interventions, what would you recommend are the most impactful for PFA?
So are you basically asking about if you have any person, we have some training in psychology in general? I think DBT skills, they are great.
Okay.
Because you can use distraction skills, you can use stress tolerance skills. So DBT skills, even if you doesn't have any training, formal DBT, you can access some training on just the skills. And DBT in general is moving to teach providers in general, like health providers in general, to learn some of the skills. So those are great to use a part of the intervention. And so Linda clarified for us, so it's called critical incident stress debriefing. Are you familiar with that, or have you been exposed to that one? No, I mean, I'm sure that they have parallels because, you know, the themes of a disaster or acute traumatic events share a lot of similarities, right? And so maybe they do have some overlap, but I guess we'll have to look into that one a little bit more. Another question, Dr. Irizarry, is, are there certain individual characteristics of people impacted by a disaster that reduce the effectiveness of PFA? That's a really good question. I think that everything is going to start with the rapport. So if you are not able to have like a good engage at the beginning, probably that's not gonna work. And probably it's gonna be a good time to offer them the opportunity to receive help from other people that are with you, or some people they doesn't feel ready to receive help. So unfortunately, they're not gonna benefit from that. Yeah.
How about the provider? How about the provider in general? Are there, like personality styles and characteristics that maybe make some people not suited to be a
Yeah.
person who delivers PFA?
Yeah. So I will say first that definitely we have to remember that it's really important that these services are provided by or are more effective when they are provided by internal resources. So, for example, if any of you go to Puerto Rico, probably they are gonna receive me better because I'm Puerto Rican and I know the culture. So that is one of the things. The other thing, in general, talking about characteristics, definitely compassion. That soft voice, soft approach, that the person might feel that you are here to give a support and you are not like diminishing their experiences, like invalidating their experiences, that's gonna make a difference. So if you usually have a more directive approach and that's not necessarily gonna be a good fit to that field, because they can feel that you are in a different situation, or if you are in a superior situation and you want to make them feel, remember that perceived understanding that you are also a survivor, and you might even share some things that you are dealing with right now, but you are trying to focus on overcome the situation.
So I'm hearing meet them where they're at, and then align with them and maybe self-disclose to like an
Yep.
appropriate professional degree so that they can feel like you're right there with them. Yeah.
Yeah, definitely don't say anything like, oh, that's material, don't worry. You're gonna
Right.
replace them, you're gonna be able to build a new house, don't worry.
Mhm.
That's not the time for that.
No invalidating. No invalidating. Yeah. You spoke about self-care. Top two, from your stance as a clinical psychologist, top two
Mhm.
types of self-care that you think are really helpful for these situations in particular.
I think that, again, core factor compassion. Practicing self-compassion, being compassionate with yourself about what are your needs, what do you need, and acknowledging your privilege is really important. And also using it in an effective way. Don't let that, if you have something that other of the survivor doesn't have, don't let that put you down, like don't let that interfere with the situation, because sometimes it happens. Sometimes your neighbor loses a house and you doesn't. So try to practice self-compassion, gratitude, and try to use those resources to help the other one. That is a thing that is really helpful. And the other one, definitely, for me, is monitoring the vulnerabilities. That is really important because we might be easily get cash on the go, 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 and we forget ourselves and we forget our things that we need to do in order to survive or in order to be effective in a long term. Not necessarily in the day, because maybe you can function one day, go, 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 go. But sometimes this is gonna last for a long time. For example, let's say in Puerto Rico, we were dealing with that 2 years, 1 year and a half. So this is something that you have to be really aware your vulnerabilities.
Yeah. Absolutely. Well, thank you so much for your time today and all the information shared. If anyone would like a copy of the slides or the recording, might not be able to get it out today, but next week we'll be able to send that if you just email behavioral health education at bmcjax.org. And David Morrell provided some further context for the group. So it's a national organization. The difference, okay, it's used for group crisis, not for individuals. Understood. Okay, well, that's helpful. Well, I'm sure that they can work in harmony to a degree. And then anyone who needs a certificate of attendance who does not have a license, please email that same email provided just now, and we'll get that out to you. So if you're a CNA in the Excel program or any other component, we'll provide that. I hope everyone has a wonderful holiday weekend. Just a quick note, this is our last behavioral health grand rounds of the academic year. We'll resume tentatively in September is when we're scheduled to resume. So we hope you all have a wonderful summer, and thank you always for your attendance and support of the series. Mary, the email is in the chat. It's behavioralhealtheducation@bmcjax.com. Okay, I hope everyone has a wonderful afternoon. Monique, please email the email provided just now, and I'll get you that certificate. Okay, have a great 4th, everyone. Bye-bye.